histology slide asking about the structure which is not having the endocrine function. So there are some histology diagrams given ABCD, and we have to find out which one of the following is not having endocrine function. Let us zoom this diagram now. As you will notice, the marker A is on a structure which is having a lot of blue dots, and when you see a lot of blue dots, it is supposedly one lymphoid organ. You can see that there is this capsule sending some trabeculae inside, and then we have this collection of the WBCs, or basically the lymphocytes, making lymphoid follicles. Now these lymphoid follicles are in the 25% of the space, because 75% of the space is having this red pulp. So we are talking about red pulp and the white pulp of the spleen. Spleen is a lymphoid organ and it is not an endocrine organ. So the answer of exception should be choice number A. We identified the spleen because you have these lymphoid follicles. There is a central arteriole. In the lymphoid follicles, you will have B lymphocytes. In the central arteriole, around that you will have periartery lymphatic sheath, which will be T lymphocytes. So this is a lymphoid organ. What about the marker B? Marker B, you see there is a capsule, and then you'll find there are some layers, darker, lighter, darker, lighter. And as you look at these darker, lighter areas, you'll see this is the G, this is the F, and this is the R, GFR, zona glomerulosa, zona fasciculata, zona reticularis of the adrenal gland cortex, whereas deeper here is adrenal medulla. So this is adrenal gland. Adrenal medulla will have a lot of blood vessels, because the catecholamines like epinephrine and norepinephrine, they are being put into these blood vessels directly, endocrine organ. When you talk about the G, F and R, that is zona glomerulosa, fasciculata, reticularis, there is the salt and the sugar and then the sex, because zona glomerulosa, as you can see, this area will be giving us mineralocorticoids for water and salt balance, whereas zona fasciculata, where you will find there is the glucocorticoids being given for, say, sugar metabolism or the glucose metabolism control. And when it comes to the reticularis, there will be DHEA type, dehydroepiandrosterone type, the sexual corticoids which are being given. And so this is adrenal gland or suprarenal gland. Of course, it is an endocrine organ. If you look at this diagram, you will see a lot of serous SNI, and the serous SNI, they secrete into these ducts. This is exocrine portion, but then there is endocrine portion also, alpha, beta, delta cells giving insulin, glucagon, and somatostatin, all that. So this is the islet of Langerhans in the endocrine portion of pancreas, and that is serous SNI, exocrine portion of pancreas, giving some alkaline digestive enzymes. So of course, pancreas is definitely an endocrine organ. It is a mixed type of organ where it is exocrine plus endocrine as well. This is where you have the alpha, beta, delta cell, the islet of Langerhans. Looking at marker D, you find these are the thyroid follicles lined chiefly by simple cuboidal epithelium, and then there will be parafollicular C cells. Parafollicular C cells, they will be basically giving calcitonin, which is for calcium homeostasis. And if you're talking about the thyroid follicles, they'll give thyroglobulin, T3, T4 hormones basically. And again, it is endocrine organ, the thyroid gland, along with the parafollicular C cells. That is why in this question, it is asking which is not having the endocrine function, and our answer will be choice number A, because choice number A is basically red pulp, white pulp. Red pulp about 75 to 80% and white pulp about 20 to 25%. So this is spleen, and spleen is not an endocrine organ. That is why we have to keep our answer as choice number A. Posterior view of the brainstem is given, and we are having some markers to identify the structures. You will see here, if we are looking at the posterior view of the brainstem, there will be the midbrain followed by pons and medulla oblongata. In the midbrain, you'll have rounder elevations which are superior colliculi, and then you have this marker A on the inferior colliculi. Together they are 4 bodies, hence corpora quadri examina. We'll see another diagram to discuss the details, but this is the brain stem, midbrain part, posterior view, tectum part of the midbrain. If you look at the cerebellum is at the roof of fourth ventricle and has been removed so that you can see the floor of the fourth ventricle. Floor of the fourth ventricle, you'll have the pons and upper half of medulla oblongata. The demarcation is stria medullaris here. So as you want to look at the floor of the fourth ventricle, you would have cut the cerebellum, and for that you have to cut the three peduncles. The superior peduncle connecting midbrain, middle peduncle connecting the pons, and inferior peduncle connecting medulla oblongata. You'll notice that this large one, bundle of axons, which is shown here as marker C, is the middle cerebellar peduncle, the thickest one, lateral most. Otherwise, this will be, you can put one inferior-medial line from here, inferior-medial line here, so that above that you will find superior cerebellar peduncle. This is superior cerebellar peduncle, this is the superior cerebellar peduncle, marker B. And then you can also see there will be inferior cerebellar peduncle. So we'll look at the schematic diagram also to discuss, but my point is, if you are using the color code, let us say we are color coding the middle cerebellar peduncle with green. So middle cerebellar peduncle we are putting as green. From there you have to put one line, and that line which you are putting is going infero-medial like this, so that you can demarcate the two other peduncles. So this is the middle cerebellar peduncle. What about the superior? This will be superior, and you can do that here also. This will be superior. So superior, and this one was the middle. Whatever is left here is inferior. Inferior has been cut here, so you cannot see much of it, but the inferior will be located at this level. Let us give the color coding also. As you are giving the color coding, superior let us give the pink color, and inferior you will give some other color. Let us say we are giving the blue color. So inferior peduncle, the blue color here, and even here inferior peduncle blue color. Otherwise we have already marked the green color, and that was the middle cerebellar peduncle on the lateral side. So three peduncles we have to find out, and we have done that, and that is the marking here. Let us look at some more details by comparing it with the schematic diagram. As you compare with the schematic diagram, you will see, as mentioned, posterior view of the midbrain, that is tectum part of the midbrain, and then you will have the pons here, and then you have the medulla oblongata, which will further continue as the spinal cord. So this is the spinal cord, this will be medulla oblongata, that will be the pons, posterior view of the midbrain and all that. Up there will be the thalamus. So this region is basically the thalamus region, as you can see. And there is one epithalamus also evident. Epithalamus means it is the pineal gland. So this is the pineal gland. And then you see superior colliculus, as is evident here, superior colliculus. Also you can see the inferior colliculus. So these are the rounder elevations which are inferior colliculus. It is understood that inferior colliculus is for the auditory reflexes, and superior colliculus is for the visual reflexes. A sudden flash of light, your eyes and head neck move towards the flash of light, that is done by superior colliculus. There is a sudden sound and your head and neck move toward the source of the sound, that is the auditory reflex controlled by inferior colliculus. Together they are four bodies, so making corpora corti gemina in the tectum part of the midbrain. When you look at the cerebellum, it has been removed. How? Because we have cut the peduncle, the middle peduncle, superior peduncle, inferior peduncle, which is evident here also. This is the superior peduncle, inferior peduncle, and middle peduncle. As I mentioned, from the middle peduncle, which is the lateral most and largest one, you draw one line infero-medial. From the middle cerebellar peduncle, draw one line infero-medial, because above that will be superior peduncle, below that will be inferior peduncle. So this is the superior cerebellar peduncle, and there will be inferior cerebellar peduncle. The same thing you can do here. This is the middle cerebellar peduncle. Draw one infero-medial line. Above that will be superior cerebellar peduncle, and below that will be inferior cerebellar peduncle. This is the middle cerebellar peduncle. To identify these peduncles in dissected specimen when it is not marked. Otherwise, you can see the floor of the fourth ventricle. This is the rounder elevation, which is called as the facial colliculus, produced by the axons of the facial nerve in the lower pons, dorsal side. This is stria medullaris. Below that is the medulla oblongata, related to the floor of the fourth ventricle, because in the lower half of medulla oblongata you'll have central canal. So the upper half of medulla oblongata and the lower half of medulla oblongata. Later this central canal will continue into the spinal cord also, carrying the CSF. So these are some of the details we wanted to see, but anyway, As you are talking about the markers, we already have known this is inferior colliculus, that will be superior peduncle, there will be middle peduncle, inferior peduncle, and that is why choice number B should be our answer then. Lateral view of the cerebrum is given, especially from the left side where you have these language areas as well, asking about the marker A, marker B, marker C, and marker D. From the lateral view, you can see there's a lateral sulcus. Below that is the temporal lobe. In the temporal lobe also, you'll find that there is anterior and posterior part of the superior temporal gyrus. Since it is posterior part, maybe it is area number 22, Wernicke's sensory speech area for comprehension of language. This marker D is occipital visual cortex area, which is area number 17 for vision. And there will be one imaginary line which we are drawing, which is following the parieto-occipital sulcus seen on the medial side of the cerebrum, not the lateral side. You'll find that there is also what is called as the central sulcus running anterior inferiorly. And in front of that, they have shown this marker B. This is frontal motor cortex, area number 4, having upper motor neurons to control lower motor neurons and control the skeletal muscles. So frontal motor cortex. And this just in front of that is frontal eye field, area number 8, which is in the middle frontal gyrus, more posteriorly. And that is what they are asking about, scanning eye movement or conjugate eye movement. Say for example, left frontal eye field is activated, area number 8 is activated. It will be sending axons which will cross the midline and then will be activating PPRF or the right side, parapontine reticular formation. This PPRF of the right side will activate the 6th nucleus and lateral rectus will move the eye to the right side. But then this 6th nucleus will send some axons and they will be ascending into medial laryngeal fasciculus to activate nerve number 3 on the left side, and medial rectus will be activated so that this eye will move towards the right side. So frontal eye field leads to conjugate eye movement or saccadic eye movement or scanning eye movement towards the right side. If there's a lesion in the left frontal eye field, the patient cannot follow the object to the right side because his lateral rectus and medial rectus are not working. What will happen if there's a lesion in the left frontal eye field, area number 8, cannot see the object moving toward the right side and the eyes will be actually pulled towards this side, the side of the lesion. What will happen if there is left medial longitudinal fasciculus damage which was connecting the right 6th nucleus with the left 3rd nucleus, will be internuclear ophthalmoplegia. This right eye will move, lateral rectus will be working, but left eye will not move because the MLF is compromised. So internuclear ophthalmoplegia, all these are important details in this context. So obviously our answer will be choice number A. You can even draw your diagram looking from the lateral view of the cerebrum. So lateral view of the cerebrum, you will have this lateral sulcus. This is the lateral sulcus. Not only we have lateral sulcus, we have this anterior inferior running sulcus, which is the central sulcus. That is how you divide frontal from the parietal lobe. Below the lateral sulcus is the temporal lobe, and then there's this imaginary line. Behind that, you'll have the occipital lobe. One marker is on occipital lobe, so that is area number 17, occipital visual cortex. There was a marker on area number 17, occipital visual cortex. There was a marker here, frontal motor cortex, area number 4, having upper motor neurons to control lower motor neurons and skeletal muscles. Then there's a marker here, that is area number 8. So here the frontal lobe can be divided into 3 parts: superior frontal gyrus, middle frontal gyrus, inferior frontal gyrus. Middle frontal gyrus more posteriorly will be the frontal eye field, and that is where the marker was. Scanning eye movement, saccadic eye movement, horizontal conjugate eye movement. And if you talk about the inferior frontal gyrus, here you will have area number 44, 45, that is the Broca's motor speech area. If you look at the superior temporal gyrus more posteriorly, this will be area number 22, that is Wernicke's sensory speech area. If you are more anterior, it is area number 41, 42, that is superior temporal gyrus, the temporal auditory cortex for hearing purpose. Same diagram you will find in this 22nd edition of Harrison, and you can tell the details again. This is the central sulcus which is coming down. In front of that is area number 4, which is frontal motor cortex. In front of that is the frontal eye field. That was the area marked, area number 8. You will see that the frontal motor cortex, you have superior, middle, inferior frontal gyrus, superior frontal gyrus, middle frontal gyrus, inferior frontal gyrus. It is the middle frontal gyrus more posteriorly. This is the area number 8. That is what they were asking for. In the inferior frontal gyrus, you'll have Broca's motor speech area number 44 and 45. If you follow the lateral sulcus, this is the lateral sulcus, and you'll find that more anteriorly it will have area number 41, 42, which is superior temporal gyrus for hearing purpose. More posteriorly, you'll have Wernicke's sensory speech area number 22. So this is area number 41, 42, which is temporal auditory cortex more anteriorly, and area number 22, which is Wernicke's sensory speech area for comprehension of the language. If you go more posterior, area number 17, occipital visual cortex. So that is why in this question they are asking which area is for scanning eye movement, frontal eye field. Frontal eye field, that is area number 8, middle frontal gyrus but more posterior, and that is this area number marker A. So marker A is your answer. If there is a lesion of frontal eye field on the left side, the eyes cannot move to the right side and they will pull towards the left side, keeping your answer as choice number A then. Sagittal section of the brain, and talking about this arrow marked structure forming the medial boundary of which ventricle, lateral, third, fourth, or there is this cisterna magna also mentioned. The largest ventricles are the lateral ventricles, C-shaped ventricles in the cerebrum. Most of the choroid plexus is there forming CSF. From there, the CSF will enter interventricular foramen of Monro to enter the third ventricle, which is a midline ventricle sandwiched between the thalami and hypothalami. From the third ventricle, the CSF will move into the midbrain cerebral aqueduct of Sylvius. From there, it will go to the fourth ventricle. Fourth ventricle, which is sandwiched between brainstem anterior, especially pons and upper medulla, and cerebellum posterior. And then fourth ventricle, the CSF will move into central canal. Central canal begins in the lower half of medulla oblongata and continues into the spinal cord. Now, as we look at this diagram, you will notice the very first thing is this corpus callosum, which is evident. Corpus callosum is the crossing fiber, commissure fibers connecting right half of the cerebrum with the left half of the cerebrum. So corpus callosum. Below that, you can see this is the fornix. Fornix is also having some commissure fibers connecting hippocampus on right and left side, though it also has the projection fiber, association fibers. Let us mark them, and let me first mark with green color the corpus callosum. So green color I am using for marking the corpus callosum, and you can also mark the fornix here. As you are marking the fornix, let us use the pink color. This is the fornix region here. Now between the two you have septum pellucidum. That is what they are showing. So this is the septum pellucidum. Septum pellucidum is attaching superiorly to the corpus callosum, inferiorly to the fornix, and it is basically the medial wall of the lateral ventricle. So two lateral ventricles, they will be separated by a septum, and that is septum pellucidum, and it is forming the medial wall of the lateral ventricle. That is what the question is. The CSF, which will be in the lateral ventricles like C shape, they will be. The CSF from there will be passing into this foramen, which is interventricular foramen of Monro, and from there the CSF will be passing in this hypothalamic sulcus, which is the lateral wall of the third ventricle. From there the CSF will move into this area, which is cerebral aqueduct of Sylvius, because these are superior colliculus, inferior colliculus, the tectum part of midbrain, this is the tegmentum part of midbrain, and in between is the cerebral aqueduct of Sylvius. And then the CSF will go into fourth ventricle, behind which is the cerebellum, and in front is the pons and upper half of medulla oblongata. So this is the fourth ventricle. Let us show it with the color demarcation. As we are mentioning, we can use the blue color. This is the interventricular foramen of Monro. The CSF will come here from lateral ventricle. And as we continue marking, the CSF will be then passing through this hypothalamic sulcus, which is in the lateral wall of the third ventricle. And from there, the CSF will then enter this cerebral aqueduct of Sylvius, which we are showing here in the midbrain. And from there, the CSF will be passing into this fourth ventricle. I'm using this color code blue to show it. Let us use the black color also, like this is foramen of Monro, and from there it is the hypothalamic sulcus in the third ventricle lateral wall. Then it is the cerebral aqueduct of Sylvius in the midbrain. This is the cerebral aqueduct of Sylvius in the midbrain. then it is the fourth ventricle here. This is the fourth ventricle. And then you have central canal. Central canal will begin in the lower half of medulla oblongata to continue in the upper part of spinal cord and throughout the spinal cord. Now, once you have this kind of orientation, you can look at a coronal section from the front view. You have taken a coronal section of the brain, removed the anterior part of the brain, looking at the remaining part of the brain from the front view. These are the lateral ventricles. They'll have a lot of choroid plexus forming a lot of CSF. That CSF which is formed in the lateral ventricles, you can see this is the septum pellucidum, which is separating lateral ventricle of both sides. Above that, this is the corpus callosum. So let us shade the corpus callosum also here. As you use the green color, say this is the green color for the corpus callosum up there, and septum pellucidum you can show in say pink color. So pink color we are showing the septum pellucidum, like you can see this is the septum pellucidum separating lateral ventricle on either side, and below this is one fornix on right and left side. So you can use say blue color. As you are using the blue color, this is for the fornix. Let me zoom the area and tell you, because this is a coronal section front view, that will be the corpus callosum. This is septum pellucidum, and that is fornix on right side as well as left side, because you're looking from the front view. We have already seen that septum pellucidum is connected to corpus callosum up there and fornix below there. So that is how you identify septum pellucidum. It is the medial wall of lateral ventricle, medial wall of lateral ventricle. This is the third ventricle, which is sandwiched between the two thalami. This is thalamus, the right thalamus here and left thalamus here, and even some part of the hypothalamus also is related to third ventricle. This is the third ventricle region. With that orientation, as you already would have found your answer, the arrow mark structure which is here is septum pellucidum, and they are asking for medial boundary, so medial boundary of the lateral ventricle. If you are talking about the third ventricle will be related here, like you see this is the diencephalon part of the brain. Above that is thalamus, below that is hypothalamus, separated by hypothalamic sulcus. So all that will be third ventricle. And if you are talking about the fourth ventricle we already have shown here. This is the fourth ventricle, related to the pons and upper medulla oblongata anteriorly as the floor of fourth ventricle, and cerebellum posteriorly as the roof. If you say cisterna magna, it is basically cerebellomedullary area posteriorly between cerebellum and the medulla oblongata, containing CSF again, but CSF, when it has reached here, it was coming out from the fourth ventricle, like there will be a midline Magendie foramen and two lateral Luschka foramina, and Magendie Luschka foramina, they let the CSF out of ventricles to reach the subarachnoid space, and one of that is cisterna magna. So it is a cistern and it is extra ventricular area. Here, since they are marking this particular area, septum pellucidum, so we keep our answer as lateral ventricle. It is the medial wall of the lateral ventricle. Choice number A should remain the answer. 65-year-old male patient is presenting gradually developing the tingling sensation and numbness in the right upper limb for past 3 months. He is also having the triad of Horner syndrome. As you see, right eye, there are some visual disturbances mentioned as miosis and ptosis and anhidrosis on the right side of the face. That means right-sided Horner syndrome, the triad of Horner syndrome. Some patients may or may not have anhidrosis. They will have ptosis, miosis, but this may be missing, but here it is present. And a chest X-ray is showing apical lung lesion. That means it could be Pancoast tumor. This could be a case of Pancoast tumor on the right side, apical lung cancer compressing the cervical sympathetic chain. That will be the answer. It will also affect the lower trunk of brachial plexus. That is why the patient is having some tingling numbness in the right upper limb also. We'll see some diagrams. So compression of which of the following structure is producing this feature, and our answer will be cervical sympathetic chain. Horner pathway is 3 order neurons. The first order neuron is coming from hypothalamus to the T1 sympathetic neurons in the spinal cord, so we call it as hypothalamospinal pathway. The second order neuron will start from the T1 sympathetic neuron in the lateral horn cells of spinal cord and will be ascending in the sympathetic chain. The second order neuron are the preganglionic fibers to reach the superior cervical ganglion. Superior cervical ganglion in the sympathetic chain will give third order neurons, and these third order neurons, they will be carried by blood vessels like external carotid artery to the face, vasoconstriction, sympathetic vasoconstriction, and sweating. And some of the fibers, third order neuron, will be passing internal carotid artery through the cavernous sinus so that they can send the fibers to the superior tarsal muscle, part of Miller, for upper eyelid elevation, and then dilator pupillae. If anything goes wrong with the first order neuron, hypothalamic spinal pathway like medullary syndrome, lateral medullary syndrome, Wellenberg syndrome. If there's a right Wellenberg syndrome, first order neuron is compromised. There'll be ptosis, meiosis, and anhydrosis because sympathetic vasoconstriction is not there. So there'll be more of peripheral vasodilation, red face, dry face because sweating is not happening. There is ptosis because superior tarsal muscle, part of Miller, is not working. There is meiosis because if dilator pupillae supplied by T1 sympathetic pathway is not working, then sphincter pupillae supplied by third nerve become more powerful, causing meiosis. So meiosis, ptosis, anhydrosis. There'll be congestion in the conjunctiva, nose, and face. They all become red and dry because no sweating. That is first order neuron injury, Wellenberg syndrome. There can be also apical lung cancer, which is compressing the second order neuron. That is the sympathetic chain area, cervical sympathetic chain. In that, you'll find again these three problems like meiosis, ptosis, and anhydrosis. But if the third order neuron you talk about, there are two pathways, one following external carotid artery, the other following internal carotid artery. And that is what there'll be a difference. Let me show all this diagram in this schematic diagram. As I'm telling you, first order neuron start from the hypothalamus and it will going to the spinal cord T1 lateral horn cells. So this is the first order neuron, hypothalamospinal pathway. You'll find that detail in Harrison also. Harrison will tell. If the first order neuron is damaged in the lateral medullary ischemia, Wellenberg syndrome, there will be ipsilateral Horner syndrome features, 3 features especially. It is more than 3, but 3 you can discuss because this superior tarsal muscle, part of Miller, is not working. There will be partial ptosis. Because dilator pupil is not working, the sphincter becomes more powerful. There will be meiosis. And because the sweat glands are not working, there will be anhydrosis. But along with that, you'll also see redness of the face because if sympathetic system is not working, parasympathetic vasodilation. So the blood vessels, they are not having vasoconstriction because sympathetic vasoconstriction gone, vasodilation. So there'll be a lot of redness on the same side. So this was the first order neuron. What about the second order neuron? Second order neuron starts at the T1 spinal cord lateral horn cells and it will be passing the sympathetic chain related to the apical lung and then it goes to superior cervical ganglion in the neck region. This is second order neuron, preganglionic fibers. If there is apical lung cancer, Pancoast tumor, then second order neuron is damaged, which is preganglionic fibers which are damaged. So again, 3 plus problems. Problem number 1, superior tarsal muscle is not working, partial ptosis. Problem number 2, dilator pupil is not working, so there will be meiosis. Problem number 3, there is no sweating. Problem number 4 will be the red face, redness, congestion, conjunctival congestion, nasal congestion, facial skin congestion. So that was second order neuron. What about the third order? Third order neuron starts from the superior cervical ganglion and follow 2 arteries. There will be a sympathetic plexus around the external carotid artery for sweat gland and the vasoconstriction. On the other hand, the pathway also passes internal carotid artery, passes the cavernous sinus so that it can supply these 2 muscles, namely superior tarsal muscle and the dilator pupillae. The point is, if there is a cavernous sinus pathology like internal carotid artery dissection, T1 sympathetic plexus around that will be compromised, leading to partial ptosis and meiosis, but there will be no anhydrosis. Why? Why in cavernous sinus pathology there will be no anhydrosis, there will be no loss of sweating? Because whatever the lesion level is, problems are distal to that, not proximal. In such a case, which is cavernous sinus pathology, internal carotid artery dissection, it is all given in Harrison medicine. Still, this external carotid artery pathway is working, sweat gland is working, so no anhydrosis. It is important to know because in this question, as they are asking about the Horner syndrome, because there is meiosis, ptosis, and anhydrosis also. Anhydrosis, if you find, then lesion could be first order neuron, second order neuron. It could be third order neuron lesion also, but cannot be this, because if there is sympathetic plexus around internal carotid artery damage, this patient will have only ptosis meiosis. They will not have anhidrosis because external carotid artery pathway is already given. So that cannot be the answer. Oculomotor cannot be the answer because it will be down and out eye, fixed dilated pupil. That is not the clinical feature here. Cannot be vagus nerve. Vagus nerve, there will be other problems like hoarseness. So the only possible answer is cervical sympathetic chain is compressed. Second order neuron is compressed. It is the preganglionic fibers which are compressed, and it is apical lung cancer. It is Pancoast tumor. And Pancoast tumor not only has compromised the sympathetic chain leading to ipsilateral Horner syndrome, ptosis meiosis and anhidrosis, but it is also affecting the lower trunk of brachial plexus. That is why root value C at T1, basically that is the little finger and middle elbow, like you see in clump case palsy, sensory loss. So that is why there is tingling and numbness, because lower trunk of brachial plexus is also compressed by this Pancoast tumor or the apical lung cancer. So cervical sympathetic chain leading to features of the ptosis meiosis and anhidrosis, right-sided Horner syndrome. Choice number B should remain the answer. We are being asked about the pharyngeal arch arteries and their remnant or the derivatives in the adult. You see, we have to identify most appropriate matching regarding the embryonic aortic arches and their corresponding adult derivatives. Obviously, first pharyngeal arch artery disappears, but leaving behind a part of maxillary artery, fine. Second arch, yes, stapedial and hyoid artery, partly they are contributed by second arch, otherwise second arch disappears. Actually, arch number 1, 2 and 5, they disappear. It is only arch number 3, 4 and 6 which will be giving significant contributions, like third arch gives common carotid artery plus the initial part of internal carotid artery, also right side or left side. The fourth arch is different on right side, left side. On the right side, it will be giving a part of the right subclavian artery, but on the left side, it will give part of arch of aorta between two branches, that is left common carotid and left subclavian. Between that, arch of aorta come from fourth arch, left side. We'll see a diagram. But sixth arch is not giving arch of aorta, so that is to be excluded. Sixth arch actually gives pulmonary artery on both sides and also ductus arteriosus, which will be remaining only on left side. So let us look at the diagram. You see, the first pharyngeal arch, maybe right side or left side, they disappear, leaving behind a part of maxillary artery. On the other hand, the arch artery number 2, it is also disappearing, leaving behind part of stapedial and hyoid artery. It is part 3, part 4 and arch artery 6, they are having significant contribution in the result. Like the third arch is giving not only carotid arteries but proximal part of internal carotid artery, which can be seen in the diagram on the right and left side. Similarly, it is synchronous. So common carotid artery maybe on this side and internal carotid artery maybe right side or maybe on the left side. So internal carotid, common carotid on right and left side both come from third arch artery. When it comes to fourth arch artery, as I mentioned, right side it is part of right subclavian artery, beginning of right subclavian, and on the left side it is arch of aorta between two branches of arch of aorta, that is left common carotid, left subclavian, which can be seen in the diagram. You see, only part of the right subclavian artery, initial part, is given by fourth arch on the right side. Left side you can see this part of arch of aorta. So what is this part of arch of aorta? That is between the two branches. One is called as the left common carotid, other is called as the left subclavian artery. So between them, this part of the arch of aorta come from left fourth arch artery, which is mentioned here. What about the fifth arch? Fifth arch is rudimentary in humans, so it doesn't contribute anything, no remnant as well. But sixth arch, which is shown here in violet color, right and left pulmonary artery and also ductus arteriosus. But remember, right regressus and left is left, means ductus arteriosus is left only on left side, as shown in the diagram. The ductus arteriosus is left only on the left side along with the pulmonary artery, though pulmonary artery on the right side is also from sixth arch artery. So this gives you some basic idea. As we can see, we had to choose the most appropriate matching and we have done that. It is excluding the 5 because 1, 2, 3 and 4 we have discussed. First arch maxillary, second arch stapedial hyoid, third arch common carotid plus internal carotid, fourth not only is part of right subclavian but part of arch of aorta on the left side. but this is to be excluded, and we have done that. The answer should be choice number C. 4 individual cranial bones are shown, and the question is asking about a cranial nerve which is direct extension of the CNS. It is the cranial number 2, optic nerve. Optic nerve is the nerve of diencephalon. The diencephalon part of brain extend into the eyeball to become retina and optic nerve. So optic nerve is not a true nerve, it is a part of CNS. It is a CNS tract. That is why the optic nerve is myelinated by oligodendrocytes. That is why in multiple sclerosis, which is a problem of oligodendrocytes, CNS myelination, it is only the optic nerve which is involved. Multiple sclerosis patients can develop blindness. Multiple sclerosis is not affecting any of the peripheral nerves as such. So it is the optic nerve which is a part of CNS. If you talk about the olfactory tract, you will see olfactory bulb till that level. It is the extension of the telencephalon part of the brain, but the olfactory nerve itself, which is starting at the roof of the nasal cavity and reaching the olfactory bulb, piercing the craniform plate of ethmoid bone. This cranial number 1 is not a CNS tract, and it is not even myelinated. So you cannot take your answer as cranial number 1 because it is not a CNS tract. It is just a nerve with bipolar neurons, peripheral and central. The peripheral for taking the smell and central to synapse in the olfactory bulb. Olfactory bulb itself is an extension of telencephalon, but not the olfactory nerve. Keeping that in mind, we are being asked about a bone which is letting pass a cranial nerve and considered as the direct extension of CNS, that is optic nerve. So I'll take my answer as the sphenoid bone, because in the sphenoid bone you'll have one optic canal, and through the optic canal passes optic nerve. Though we understand that there will be superior orbital fissure here, now number 3, 4, 6 and even branches of 5, 1 will be passing here, but none of them are CNS tract. They are not extension of CNS directly. If you look at this bone, let us magnify these diagrams. What I am telling is that this is the place where you have optic nerve passing in the optic canal. This is front view of the sphenoid bone. Sphenoid bone is a butterfly shaped bone. We are looking from the front view. This is the body of sphenoid, which is pneumatic bone, empty, hollow from inside. Sphenoid air sinus is there. There is a lesser wing, there is a greater wing, there is this pterygoid process, lateral pterygoid plate, medial pterygoid plate. So like a butterfly, these are the legs of the butterfly. Now when the lesser wing comes and joins the body, here you will have optic canal for the posterior optic nerve. So this will be my answer. Though we understand superior orbital fissure will have now number 3, 4, 6 and branches of 5, 1, that is the lacrimal, frontal and nasociliary nerve, but these are not CNS extension. So cannot take that answer. Even if you look at these openings, you'll see that foramen rotundum is letting pass the maxillary nerve, that is the second branch of the trigeminal, but again it is not a CNS tract, it is not an extension of CNS. So only thing is optic nerve. What about this bone? This is actually the cribriform plate or ethmoid bone, superior view of the bone, and it is, you can say, floor of anterior cranial fossa. So at the floor of anterior cranial fossa, you'll see this is the bone having multiple openings for the passage of cranial number 1. Cranial number 1 olfactory nerve is not a CNS tract. Olfactory bulb is, but not the olfactory nerve. So we cannot take this as the answer. This bone is also pneumatic, and this is ethmoid air sinuses, you can see, but that is not our answer because cranial number 1 is not a CNS tract. What about this bone? This is actually internal auditory meatus, which you can see in the petrous part of temporal bone. So the number 7 and 8 will be passing. Neither of them are CNS extension. They are true peripheral nerves. They are myelinated by Schwann cells and they are not CNS extensions. Looking at this bone, front view of the maxilla bone, you can see the upper teeth, maxillary teeth also, and there will be one nerve passing here, inferior orbital foramen, so inferior orbital nerve, which is itself continuation of the maxillary division of trigeminal, but this is not a CNS tract again. That is why in this question we'll take our answer as choice number A, that is the sphenoid bone, telling that it has this optic canal when lesser wing attaching to the body. In the optic canal it is cranial number 2, and only the cranial number 2 is a CNS tract, which I told you myelinated by oligodendrocytes, hence proving that it is a CNS tract. And one more thing, if optic nerve is damaged, it will never regenerate, because for regeneration you need Schwann cells. Schwann cells are present only in the periphery. All the peripheral nerves can regenerate, but not the optic nerve, because optic nerve doesn't have Schwann cell sheaths. So once gone, it's gone. So we'll keep our answer as choice number A, the sphenoid bone. The nerve is optic nerve. Muscles of mastication, they develop in the first pharyngeal arch, and the nerve of first pharyngeal arch is mandibular nerve branch of trigeminal. It will be passing foramen ovale. So the question is asking which foramen is for the passage of the nerve that supply muscles of mastication, and basically they are asking for mandibular nerve branch of trigeminal nerve passing foramen ovale. So we have to locate foramen ovale. Let us zoom this diagram now. As you zoom this diagram, it is the superior view of the cranial cavity, floor of the anterior cranial fossa, floor of the middle cranial fossa, and floor of the posterior cranial fossa. This is posterior cranial fossa, this is the middle cranial fossa, and that is the anterior cranial fossa. You can see some markers. This is the marker in the lesser wing of sphenoid. When the lesser wing of sphenoid comes and it is attaching to the body of sphenoid, which is here, at the junction you will have the optic canal for the passage of the optic nerve. So this is about optic nerve, marker A. That is not our answer. It doesn't supply muscles of mastication, of course. Then what about this openings in the greater wing of sphenoid? Rotundum, ovale, and spinosum. Foramen rotundum, foramen ovale, and foramen spinosum in the greater wing of sphenoid at the floor of middle cranial fossa. If you look at the foramen rotundum, that is marker B, it is where the phi 2 maxillary nerve branch of trigeminal will be passing. And if you look at this oval foramen, marker C, it is the foramen ovale. That should be our answer, because that is where phi 3 mandibular nerve branch of trigeminal is passing. And if you are talking about this foramen lacerum, it has lacerated margin, and through that basically some nerves are coursing. Like you will see, there will be T1 sympathetic plexus around the internal carotid artery, and that will be giving the deep petrosal nerve. Deep petrosal nerve will join the greater petrosal nerve branch of the facial nerve. Together they will form Vidian nerve of pterygoid canal. So deep petrosal nerve and greater petrosal nerve joining to form Vidian nerve of pterygoid canal will all be seen at the floor of foramen lacerum, but none of that is supplying muscles of mastication. So foramen lacerum, marker D, should not be our answer. As you can make out now, since they are asking for the muscles of mastication, which is supplied by mandibular nerve branch of trigeminal passing the foramen ovale, that is why we have taken our answer as foramen ovale, which is marker C. If you are talking about marker A, it was the optic nerve. If you are talking about marker B, it was the phi 2 maxillary nerve branch of mandibular passing foramen rotundum. If you talk about marker D, it was foramen lacerum. There you had the deep petrosal nerve joined by greater petrosal nerve so that they can form the Vidian nerve of the pterygoid canal, but they are not supplying muscles of mastication. That is why our answer should remain choice number C, that is foramen ovale. In foramen ovale, you have one more nerve, lesser petrosal nerve, which carry preganglionic fiber to the aortic ganglion, working for the parotid secretion, preganglionic fibers. Lesser petrosal nerve is also present in foramen ovale, but anyway, here our answer should remain mandibular nerve branch of trigeminal, and choice number C, that is foramen ovale. This question is upon dysphagia, and you have to talk about some of the pharyngeal muscles. They have given a sagittal section, dissected specimen. When you talk about the pharynx, you should remember three pharyngeal constrictors. There will be superior pharyngeal constrictor, middle, and the inferior pharyngeal constrictor. They constrict, and in a sequence, they'll push the food downwards towards the esophagus. If anything goes wrong with these constrictors, there will be problem of swallowing or dysphagia. Then there are three more muscles in the pharynx, and they are named according to the attachments. Say from the eustachian tube, you have salpingopharyngeus, origin insertion. Insertion is into pharynx only. And styloid process, so stylopharyngeus. Palate, so palatopharyngeus. These muscles are going to pull the pharynx up to take the bolus of food inside. If anything goes wrong with the three constrictors or anything goes wrong with the three longitudinal muscles, there might be dysphagia. So keeping that in mind, let us zoom this diagram. It is a sagittal section of the head and neck. You can see that superior turbinate, middle turbinate, inferior turbinate in the lateral wall of the nasal cavity is evident. You can also see the hard palate here, and then there will be soft palate down there, uvula. And you can see the upper teeth here. You can see the tongue also, major bulk of the tongue made by genioglossus muscle. So what is this muscle here which is going towards the palate? It is actually tensor veli palati, developing in first pharyngeal arch supplied by mandibular nerve branch of trigeminal. Then you'll have one muscle which is shown here, which is marker B now. It is coming from the eustachian tube and going to insert into the pharynx. Coming from eustachian tube, salpingo. So salpingopharyngeus. Let me mark it in some color. Let us first mark the tensor veli palati in green color. So this tensor veli palati we are marking in green color. This green color is tensor veli palati, but it is not for swallowing as such, so it should come out. This is the answer of exception. Now let me mark the other one, use the pink color, and it is coming from the eustachian tube. I'm using the pink color, and this muscle will come and it will be inserting. I'll be showing you a few more diagrams to make it more clear. Inserting into the pharynx. So this is salpingopharyngeus, and of course salpingopharyngeus, which is elevator of the pharynx for taking the bolus of food inside. So if it is compromised, there will be subtle difference of dysphagia can be one of the feature if it is not working. Then what about this muscle which is still more posterior, marker C? If you look at the marker C, let me use the blue color for marking it. This is a muscle which is actually going like this, and posteriorly there will be a midline raphe also. The constrictors, first there will be superior constrictor which will be attaching almost to the base of the skull. There will be a gap, of course, through that gap you have this eustachian tube passing, but superior pharyngeal constrictor then merging with middle pharyngeal constrictor. Basically it is showing the pharyngeal constrictor, superior and middle pharyngeal constrictor level. And of course if something goes wrong with the constrictors, then there will be difficulty in swallowing, dysphagia. What about this marker D then? As you will choose some other color, let us take this pink color or maybe the bluish color, and it will be coming from the palate, violet color, and then going into pharynx. So marker D coming from the palate, this is the soft palate, so palatopharyngeus, and of course palatopharyngeus is also muscle of pharynx. If you compromise it, there will be difficulty in swallowing or dysphagia. So as is evident, tensor veli palati, paralysis of this muscle will not lead to dysphagia as such. But of course salpingopharyngeus or the pharyngeal constrictor, superior middle, or the palatopharyngeus, if they are involved, there will be dysphagia. To give you more better idea, let us zoom this area. As I am mentioning, there are laryngeal pharyngeal elevators like stylopharyngeus, palatopharyngeus, named according to the place they are coming from, like styloid process giving, so stylopharyngeus muscle, and it is coming from the palate, so palatopharyngeus muscle. And then there are three constrictors, superior, middle and inferior constrictors. As you will see, these muscles, they keep coming posteriorly. There's a midline raphe, and they will come from, say, they attach to the hyoid bone, thyroid cartilage, cricoid cartilage, hence the name cricopharyngeus, thyropharyngeus. So these are the constrictors. If they are compromised, there will be dysphagia. The muscle which they have shown, tensor veli palati, is here. Behind that there is a levator also. So let me correlate the diagram. In this diagram you will notice this muscle which we are talking about, it tensor veli palati. This muscle is the tensor veli palati. So tensor veli palati is not going to be giving us problem of dysphagia as such. If you look at this muscle now, that is salpingopharyngeus, it is not evident in this diagram. You have another diagram to discuss that. Even for the palatopharyngeus, it is better to see the next diagram. And if you are talking about the constrictors, constrictors are evident, like superior middle pharyngeal constrictors are evident. So, but to have some more idea, you see this diagram. Now, where is this tensor veli palati here? Tensor veli palati is here, tensor veli palati. You'll see it is the more anterior muscle. Behind that is the levator. So levator is behind that. Like in this diagram, if you want to see levator, this is levator veli palati, and here the levator veli palati is here. These muscles, they basically work upon the palate and the eustachian tube. and they might be opening your suction tube and all that, but not for swallowing as such. Then where is this salpingopharyngeus muscle? Marker B. Salpingopharyngeus is here, you can see. Let me shade that with some color. Let us use green color. Salpingopharyngeus, as I am using green color for that, salpingopharyngeus. So salpingopharyngeus is shown in green color. It is coming from your suction tube. You can see your suction tube is passing and it is having the attachment of this muscle. It can contract, elevate the pharynx for swallowing, and it can be, if it is compromised, there can be dysphagia. Then what about the muscle which we were talking about, this pharyngeal constrictors? We'll see there is a superior pharyngeal constrictor, there's a middle pharyngeal constrictor, and there's an inferior pharyngeal constrictor. They all come to the posterior side and they merge in a midline raphe. So let me show that in, say, blue color. And this is superior pharyngeal constrictor. Then you have the middle pharyngeal constrictor. Outside will be inferior pharyngeal constrictor. But these blue colors, superior or middle or inferior pharyngeal constrictor, if they're compromised, there'll be, of course, dysphagia. So what you are seeing as marker C is superior pharyngeal constrictor mostly. Then what about this marker D? Marker D, you can see from the palate it is coming. So palatopharyngeus, let me color code it with some other color. Let us use the pink color. So coming from the palate and going to pharynx. So pink color palatopharyngeus. As you see, this is the pink color palatopharyngeus. We have used the blue color for the pharyngeal constrictor, like superior pharyngeal constrictor, middle pharyngeal constrictor. We have used the green color for the salpingopharyngeus. So this is the green color. And then you can use another color, let us say black color, for tensor veli palati, black color tensor veli palati. So it is obvious that in this diagram, tensor veli palati is the answer of exception. If it is compromised, there won't be any dysphagia as per se. Otherwise, these are pharynx muscles. And of course, if they are compromised, there will be dysphagia. That is why in this question, which of the following muscle is least likely to be associated with dysphagia, we'll take our answer as tensor veli palati. Choice number A should remain the answer. Patient presenting with the difficulty in opening the mouth, means depression of the mandible. There are three muscles. Specifically, we talk about lateral pterygoid, but also muscles attaching mandible with the hyoid, that is mylohyoid and entry belly of digastric, three depressors. There are three elevators also, MTM elevators, but they are for closing the mouth. Masseter, temporalis, medial pterygoid for closing the mouth. So this is mostly lateral pterygoid they are talking about, because closure is fine. So MTM elevators are working fine. So there is a dysfunction of the muscle, which is lateral pterygoid. What is false about the muscle? You have to remember these muscles of mastication, they are developing in first arch, and first arch is being supplied by mandibular nerve branch of trigeminal. So mandibular nerve branch of trigeminal will supply some of the muscles of mastication, and in these muscles of mastication, you will see that there are three elevators, three depressors of mandible, MTM elevators. When you say MTM elevators, there is the masseter, then it is the temporalis, then there is the medial pterygoid, and they are elevators. Elevators of mandible and close the mouth. But closing of mouth is okay, as this patient is showing. Problem is with opening. So what about the openers? There are three depressors also, and in the three depressors, the very first is lateral pterygoid. Otherwise, there are muscles which are connecting mandible bone with the hyoid bone, and the muscles which connect mandible bone with hyoid bone are mylohyoid muscle, and then there is anterior belly of digastric. Now all these six muscles, maybe the three depressors like lateral pterygoid, mylohyoid, anterior belly of digastric, or three elevators of mandible to close the mouth, that is masseter, temporalis, medial pterygoid, they are all supplied by mandibular nerve branch of trigeminal. But since the question is on lateral pterygoid, remember lateral pterygoid takes its origin from the sphenoid bone. Sphenoid bone is like a butterfly, it has legs. In the legs also there is a lateral pterygoid plate. In the lateral pterygoid plate also, the lateral surface of lateral pterygoid plate, that is the origin. Though it is also taking origin, there are two heads, I'll show you a diagram. But it is the lateral surface of lateral pterygoid plate that is origin. Insertion is into pterygoid fovea. In the neck of the mandible and also attaches to the some fibers inserted into capsule, some fibers inserted to disc of temporomandibular joint. So we'll look at that diagram, but my point here is that if you look at the front view of the sphenoid bone, this is the sphenoid bone, the body of sphenoid. We have seen body of sphenoid, attaching there is the lesser wing of sphenoid, you are looking from the front view, and also greater wing of sphenoid looking from the front view. But then this butterfly, it has legs also, and those legs, the pterygoid process, you'll have pterygoid plates. There'll be a lateral pterygoid plate and medial pterygoid plate. It is a lateral pterygoid plate which will give two pterygoid muscles. You'll see if the muscle is coming from lateral surface of the lateral pterygoid plate, then it is called as lateral pterygoid muscle, which is protruder and depressor of mandible to open the mouth. But if the muscle came from the medial side of the lateral pterygoid plate, then it will be medial pterygoid muscle. MTM elevators, it will be elevating and closing the mouth. So remember, none of the muscle come from medial pterygoid plate. Both the pterygoids come from lateral pterygoid plate. If it is lateral surface of lateral pterygoid plate, it is lateral pterygoid. If it is the medial surface of lateral pterygoid plate, it is the medial pterygoid. But both the pterygoids come from lateral pterygoid plate, not the medial pterygoid plate. So immediately you'll get your answer that it is not attaching to medial pterygoid plate. It is attaching to lateral surface of lateral pterygoid plate. Of course, it is attaching to the articular disc of temporomandibular joint, also capsule of temporomandibular joint, also pterygoid fovea, anterior neck of the mandible. It is supplied by mandibular nerve. All these muscles are supplied by mandibular nerve. And this muscle, lateral pterygoid, is not only protruding the mandible but also depressing the mandible to open the mouth. It is not working. That is why patient has difficulty opening the mouth. Let me give you some more details. As you look at this diagram, again lateral view, this is the muscle we are talking about. It has upper head and it has lower head of the lateral pterygoid. It is the lower head of lateral pterygoid which will come from lateral surface of the lateral pterygoid plate. So lateral surface of lateral pterygoid plate, that is the one of the origin, and the other origin is from the greater wing of sphenoid. But insertion is here. It is to the articular capsule, articular disc, and also anterior surface of the neck of the mandible. There is a pterygoid fovea. What this muscle does is it will pull the mandible anterior and depress it, protruder and depressor of the mandible. If a question comes, what is the first answer? First answer should always be depressor, because that is the chief activity, though it is also a protruder of mandible. It can cause protrusion, but first answer is depressor to open the mouth. And number two, it can also protrude the mandible. It will aim the mandible. Take it anterior, that is protrusion. Take it inferior, depressor of mandible. Take it medial. The two lateral pterygoids, they pull the mandible medial. That is why if right-sided lateral pterygoid is not working, then left-sided medial pterygoid will become more powerful in the medial component. And if this muscle is not working, the other muscle will keep pulling the jaw toward the midline and cross the midline, and jaw will deviate to the same side of lesion. Say mandibular nerve is not working on the right side, right medial pterygoid, lateral pterygoid, all the muscles are not working, but the left lateral pterygoid became more powerful. Normally the two lateral pterygoids, they balance, but if this is not working, then this will not be balanced. It will keep pulling the tongue to midline, the mandible to midline, and then it will deviate. So as you ask the patient to protrude his jaw, it will deviate to the same side of the lesion. This is all about lateral pterygoid. That is why in this question, patient having difficulty opening the mouth. There are three muscles which open the mouth. One of them is lateral pterygoid. Other two, you know, mylohyoid and anterior belly of digastric, but all supplied by mandibular nerve. Now closing is okay. So MTM elevators are working. Masseter, temporalis, medial pterygoid are working. And of course, if you are talking about the false statement for lateral pterygoid, this is the answer, because lateral pterygoid come from lateral surface of lateral pterygoid plate, not the medial. Otherwise, of course, it attaches to articular disc, attaches to articular capsule, also attaches to pterygoid fovea on the neck of mandible. It is supplied by mandibular nerve, and it is not only protruding the mandible, it is also depressing the mandible. It is actually by depressing the mandible, that is how it will open the mouth. So the false statement remains choice number A. One vertebral bone is given and the area is marked here. They are asking about this marked area, the red color, is articulating with which bone? This is C1 vertebra, that is the atlas vertebra, identified by the fact that it has no body. There is no body with the atlas vertebra, and it is having some arches, like this is the anterior arch, that is the posterior arch. You see, cervical vertebra, they are having transverse process with some openings which are called foramen transversarium for the passage of vertebral artery. Since this is the C1 vertebra or atlas vertebra, you will find that third part of vertebral artery will come here, passing the foramen transversarium of the C1 vertebra and then arches over the posterior arch superiorly. So this is basically the superior view of the C1 vertebra. Because it is only the superior view, you will find that groove for the vertebral artery, third part. That also comes as a question. It is not the inferior view, it is superior view of the C1 vertebra, and that is why what you show here or here, the arrow mark, is the articular process for the bone, occipital bone, atlanto-occipital joint. So when you say it is atlanto-occipital joint, that is where the occipital condyles will come. It is ellipsoid synovial joint, also called as the condylar synovial joint, but ellipsoid is a better answer. So ellipsoid synovial joint, or you can say condylar, second answer in sequence. It is the one which help us in doing the nodding movement or yes movement. So obviously our answer will be occipital bone. It is not articulating with temporal or sphenoid at all, though it is articulating with axis. So what about the axis? Axis bone will be below this because it will be C2. It will have one odontoid process or dense of axis, it will come, and it will be making one pivot synovial joint, C1 C2 joint or atlanto-axial joint. So C1 C2 joint, atlanto-axial joint is for no movement. It is pivot or rotatory joint. So the axis C2 vertebra sends one prolongation, dense of axis or odontoid process, that will be articulating here, and midline joint, it is for no movement. So no movement happens at C1 C2 joint, atlanto-axial joint, pivot synovial joint. Plus, of course, this will be having inferior articular facet for the axis, but this is superior articular facet, and that is for occipital bone. That is why in this question we have to keep our answer as occipital bone. Occipital bone will come here, forming atlanto-occipital joint, and that is for the nodding movement or yes movement. That is why we keep our answer as choice number A. This is a 9-year-old boy coming to the emergency department after falling on outstretched hand, and X-ray is showing there is a supracondylar fracture, extension type closed supracondylar fracture. Most of the time it is the anterior-introsus nerve branch of the median nerve which is pulled, and there are some muscles, deep muscles of the anterior forearm, like flexor pollicis longus, the lateral half of flexor digitorum profundus, and pronator quadratus, they will be compromised. So this patient cannot make OK sign like this, because for this you need flexor pollicis longus and you need lateral half of flexor digitorum profundus, not working, so cannot make this OK sign. That is what on examination patient is unable to make the OK sign with his thumb and index finger. So I'll take my answer as anterior-introsus nerve. If it is not given, then I might take my answer as median nerve, partial injury. It is not completely injured. Because of this extension type of supracondylar fracture, only median nerve is pulled. It is not totally damaged, it is partial injury. Only those axons are compromised which enter anterior-introsus nerve. And regarding this test, you see, how do you fold the thumb? Flexor pollicis longus supplied by anterior-introsus nerve branch of median nerve, not working. How do you fold this distal interphalangeal joint? This is basically lateral half of FTP, again supplied by the anterior-introsus nerve. So if anterior-introsus nerve not working, cannot do this. Patient, when you tell him, you show this, do it like this, patient will be doing like this, because unable to fold the DIP joint of thumb, unable to fold the DIP joint of the index finger. Now, if you say your answer is anterior-introsus nerve, because the anterior-introsus nerve is supplying the flexor pollicis longus and the lateral half of the FTP, flexor digitorum profundus, and pronator quadratus, Why don't you take your answers median nerve? Because I told you it is partial injury of median nerve. Only few axons of the median nerve are damaged, which will enter the anterior interosseous nerve. That is how the supracondylar fracture present like. And if the median nerve was damaged, let us assume that median nerve was damaged, not only the anterior interosseous nerve will be gone, but there will be other problems. Ape thumb deformity will be there. Sensory loss will be there, 3.5 fingers. That is not mentioned. So you cannot take your answer as median nerve injury, because if median nerve is damaged, not only its branch anterior interosseous nerve is compromised, but median nerve itself, if it is compromised, the thenar muscle will be affected, sensory loss will be there. Have they given any of such things? No. So in this question, you cannot take your answer as median nerve, because statistically it is not involved. Statistically this is involved. But the advice is, if it was not in the option, then of course you will say this is the answer, partial injury. Why your answer cannot be ulnar nerve? Ulnar nerve, if it is damaged, you'll have ulnar claw hand deformity or sensory loss, this 1.5 fingers anterior posterior. That is not given. So why your answer cannot be brachial artery? Brachial artery, then they'll be telling like pulse is absent or there is a pale hand. Maybe Volkmann ischemic contracture, some problems will come, but that will be later. This patient has just come to the emergency department. Volkmann's ischemic contracture doesn't set in so fast. So cannot take the answer as brachial artery. The best possible answer is choice number C. Right hip bone is shown and they are marking the ischial spine. You can see this is greater sciatic notch, that is the ischial spine looks toward the medial side, and this is the lesser sciatic notch. There are some structures which pass the greater sciatic notch and lesser sciatic notch hooking behind the ischial spine. And what are those structures which will hook behind the ischial spine? And when they are hooking behind the ischial spine, they'll be in the gluteal region. So what are these structures which are for a short distance in the gluteal region? They are remembered as pin structures. So when you are talking about the pin structures, what is P for? P is the pudendal nerve. Then what is the I? Internal pudendal vessels. Internal pudendal vessels means it will be not only the artery but also the vein. What is N? N for nerve to obturator internus, as obturator internus tendon is also passing in the region. Now if you say that these pin structures were in the greater sciatic notch, then they come and hook behind the ischial spine, come to lesser sciatic notch, where they go further. They go into this pudendal canal in the lateral wall of ischial fossa. There will be a pudendal canal in the lateral wall of ischial fossa, and then they supply the perineum region. They are the nerves and vessels for the perineum. You'll see that on the pelvic surface of the ischial spine, there will be origin of one of the muscle called as the coccygeus muscle. So coccygeus muscle, full name is ischio-coccygeus. So ischio-coccygeus or coccygeus muscle is also related to the ischial spine because it is taking origin from the pelvic surface or internal surface of ischial spine. Then this is obturator foramen. From the obturator foramen on the inside is obturator internus. The tendon will go like this, and it is also related to ischial spine, but not the externus. The obturator externus is on the outside and it attaches to femur like other muscles, but it is not related to ischial spine. That is why tendon of obturator externus is not related. That will be our answer. Let us look at some more details. As you see, we are looking from the medial view of the right hip bone, like we have taken a sagittal section, remove the left part of the body, looking at the right part of the body from medial view, right hip bone. So right hip bone and the sacrum is here. You see, in the pelvis, there will be formation of S234 nerve, that is pudendal nerve. Pudendal nerve, when it is formed in the pelvic cavity, it will leave the pelvic cavity passing greater sciatic notch. It will hook behind the ischial spine. For a short distance, it will be in the gluteal region. Leaves the gluteal region, comes to lesser sciatic notch. So first of all, it is here in the pelvic cavity. Second, it is in the greater sciatic notch. Third, it is passing behind the ischial spine. Fourth, it will come to lesser sciatic notch. Then it will be passing in this pudendal canal, which is lateral wall of ischial fossa, and then giving branches towards the perineal structures. Not only pudendal nerve is passing greater sciatic notch, hooking behind ischial spine and coming to lesser sciatic notch, there are other structures also. So along with pudendal nerve, you will see internal pudendal artery vein, and nerve to obturator internus. Following the same course, if you want to give peroneal block, you can take the landmark as ischial spine and inject the anesthesia, and you will block the peroneal nerve. If you want to work on the perineum, say for example, you are working for episiotomy, then you desensitize the area by blocking the peroneal nerve. One other thing which you will notice is a muscle come from here going towards the femur piriformis, taking origin from sacrum going towards the femur piriformis, passing greater sciatic foramen or notch. So this area here you will have piriformis. As I told, the ischial spine medial or pelvic surface, you will have this muscle coming, that is coccygeus or ischio-coccygeus muscle. So this is ischio-coccygeus. Then I told that there will be obturator internus muscle going from here, going to, all of these are attaching to femur bone. So as you see, it is originating from here, obturator internus, and the tendon is passing in relation to ischial spine, but not the obturator externus. What about obturator externus then? Obturator externus is coming from obturator foramen but outside to the lateral side, not the medial side. And as the obturator externus takes origin from there, it will insert on the femur, but it has no relation as such with the ischial spine. So tendon of obturator internus is not related to ischial spine. That was the question, and this is your answer. So is the ischial spine related to peroneal nerve? Of course, peroneal nerve, interperoneal artery vein, and also coccygeus muscle, which is also called as ischio-coccygeus, but it is not related to tendon of obturator externus. Choice number D is the answer. Hip bone is given, and they are asking for the bony structure giving origin to a muscle contributing to extension both at the hip and knee joint. Now, if you read the literature, there are muscles which are working at the hip joint and knee joint simultaneously, but doing extension at both the joint is very rare. And they are basically asking about gluteus maximus, though be careful. Gluteus maximus is the chief muscle of extension at the hip joint. It doesn't work as such at the knee joint, though it will help to keep the knee joint in extension. That is there. So with the help of iliotibial tract. Gluteus maximus, 25% fibers they insert on the gluteal tuberosity, posterior femur for hip extension, and 75% fibers insert on iliotibial tract. I'll show in diagram. Iliotibial tract can help in knee extension a little bit, though that is not the function of this muscle. If you want to extend the knee joint, you have quadriceps femoris working for that, not the gluteus maximus. But for this particular question, we have to give some compensation, and we can talk about gluteus maximus here. So where is the origin or attachment? You see, this area is for gluteus maximus. So answer will be choice number A, posterior to posterior gluteal line, and also the iliac crest. That is the origin. It also attaches to sacrum, coccyx. So sacrum, coccyx, the ilium bone posterior to the posterior gluteal line, and also iliac crest. What about this area? That area is for gluteus medius, not the gluteus maximus. Medius is for abduction, medial rotation of the hip joint, also for pelvic stabilization during walking. If you look at this, that is ischial spine. Ischial spine, the view is from lateral side. From here, superior gemellus muscle comes. Superior gemellus muscle, which is undercover of gluteus maximus, helping gluteus maximus for the lateral rotation at the hip joint. So gluteus maximus also work for lateral rotation hip joint, and this is one of the short lateral rotators. So what are the functions of gluteus maximus? Gluteus maximus has several functions. One we have told is hip extension. It is the chief muscle of hip extension, and it is also doing lateral rotation helped by superior gemellus. It is also doing abduction at the hip joint, upper fibers, and it is also doing adduction at the hip joint, though most of the books will tell only these three. But you should know lower fibers can do adduction at the hip joint. And one more point which the examiner is now telling, it can do extension at the knee joint also. So these are all functions of gluteus maximus which you have to remember. What about this marker here? That is ischial tuberosity. Ischial tuberosity will have some muscles which are hamstring muscles like semitendinosus, semimembranosus, or long head of biceps femoris taking origin here. Hamstring muscles, they are of course helping gluteus maximus for hip extension, but they are not doing knee extension, they do knee flexion. So hamstrings are for knee flexion, they don't do extension. So hip extension, weak hip extensors, and chiefly they are knee flexors coming from ischial tuberosity. This is your detail. Now talking about the gluteus maximus, it's a large muscle, large origin. Ilium part of the hip bone, it will come from the iliac crest posteriorly, also come from the hip bone posterior to posterior gluteal line. So dorsal segment of ilium and even the iliac crest, coming from the sacrum and coccyx also, origin from the dorsal side of sacrum coccyx. And there's one ligament which means sacrum and the ischial tuberosity, sacrotuberous ligament, that is also origin. These are all origins. Then what about the insertion? Insertion, 25% fibers. They insert into this gluteal tuberosity, 25%, because 75% fibers, they are going into iliotibial tract, attaching to anterior surface of the tibia called as Gerdy's tubercle. I'll show you a diagram. Gerdy's tubercle, anterior surface of tibia, iliotibial tract, 75% fibers go there. That is how it can help in knee extension. That was the question. But this is 25% fibers, posterior surface of the femur, gluteal tuberosity, and that is for pulling the femur posterior, hip extension. As the muscle will contract, this is the origin, that is the insertion, the muscle will shorten, and in that shortening, it will pull the femur posterior for hip extension. But remember, upper fibers can do hip abduction also, and lower fibers can do hip adduction also. So lower fibers attaching here for hip adduction, upper fibers attaching here for hip abduction. First preferential answer is abduction. If not given, then you can take your answer as adduction also. But before you talk about abduction, adduction, you should say it can rotate the femur laterally also, lateral rotation. And for lateral rotation, you have some short lateral rotators like gemelli muscles working. Now, you are looking from such a view that you can see the gluteus maximus taking origin from the hip bone, from the sacrum bone, coccyx bone, and inserting into two parts. One, of course, it was the femur, but the other part, 75% fibers into iliotibial tract. It is called iliotibial because coming from ilium going to tibia. Tibia also, it is attaching anteriorly on Gerdy's tubercle. But that anterolateral aspect of the lateral condyle of the tibia, you see it is coming along with tensor fascial lata. So tensor fascial lata also attaches to ilium bone and merges the fibers with the gluteus maximus together. They insert on tibia via iliotibial tract. And because this, you see, gluteus maximus originate from gluteal region, it can pull the femur. Pull the femur posterior means it will cause hip extension. But since the muscle is also attaching here, it can pull the tibia anterior. If you pull the tibia anterior, then knee extension. So hip extension as well as knee extension, that is can be taken as the action of gluteus maximus. That is how we describe. You can see posterior gluteal line, and posterior to that is marker A. So marker A is gluteus maximus here. If you are talking about marker B is the region where you will have gluteus medius. You can see this is the region of gluteus medius. If you are looking at the marker C, that is the ischial spine, lateral aspect, that is superior gemellus taking origin, the short lateral rotators under cover of gluteus maximus. If you look at this marker D is ischial tuberosity, and that is where you have the hamstring muscles taking origin like semimembranosus or semitendinosus or the long head of biceps femoris. But they are helping gluteus maximus for hip extension, understood. Their chief job is the knee flexion. They pull the tibia posterior, not anterior. So that cannot be your answer because they are for knee flexion, not extension. Keeping all that in mind, which bony structure give origin to the muscle contributing to extension at both hip and knee joint? It is gluteus maximus, and gluteus maximus takes origin from here, this region. That is why our answer is marker A. Some foot deformities are given and we have to match them, like equinus, planus, cavus, or calcaneus. Equinus is referring to the horse, like the horse hoof, and planus means the arches are flat foot. Cavus means exaggerated arches, like medial longitudinal arch is very much exaggerated. Calcaneus means the patient is walking on calcaneum, that is heel. So as you will notice, equinus, like a horse, patient is walking on the toes, basically heel is up there. If the patient is having foot drop, it might appear like equinus, though not exactly because they'll have different gait. What is calcaneus? Means the patient is walking on calcaneum. So the toes will be pointing towards the sky, towards the roof. It might happen that tibial nerve, posterior tibial nerve is not working. So plantar flexion is not working. That is why there will be exaggerated dorsiflexion, because the anterior muscles are supplied by anterior tibial nerve, the dorsiflexors, they become more powerful. That is why patient will start walking on heel. Calcaneus deformity. Calcaneum is the heel bone. So this could be happening in posterior tibial nerve injury. Whereas, medially, the foot is turned medially, valgus is laterally, L for lateral. If the foot goes lateral, valgus deformity or varus deformity, like congenital talipus, equinus, varus deformity. Congenital since birth, talipus for the foot, equinus like a horse, the heel is up there, walking on toes, and varus means turned medially, the sole is turned medially. Cavus means the medial longitudinal arch has become exaggerated, and planus means the medial longitudinal arch or the arches are become, it's a flat foot, and splay means the toes are splaying away from each other. So keeping all that in mind, we have taken our matching as A2, equinus, plantar flexion of the foot. The heel is high in the air and the patient is walking on toes. Then B is 3. Planus is flattening, flat foot, cannot walk, jump, run properly. C is 4. That is cavus. It is cave-like, means like this. So high arch of foot, especially medial longitudinal arch, become very high. And D is 1, means calcaneus. Is patient is walking on calcaneum, that is the heel bone, so that the toes are pointing upward towards the roof or towards the sky. So exaggerated dorsiflexion, as I told you, could be happening in posterior tibial nerve injury. Plantar flexor are not working, so dorsiflexor become more powerful. That is why we keep our answer as choice number C.